Welcome. I'm so glad you're joining us for this deep dive today.
Yeah, it is a really great one to dig into.
It really is. If you're someone who likes to stay ahead of the curve on global health, or, if you just want to understand how massive, highly technical medical guidelines actually translate into the everyday lives of millions of people, you are in the exact right place.
You definitely are.
Today, we're immersing ourselves in a brand new, really comprehensive departmental update. This was just released by the World Health Organization on January 7, 2026.
And this is a monumental release. We're looking at the first consolidated guideline update on HIV clinical management from the WHO since 2021.
Right, which in this field is a long time.
In the realms of virology and global health logistics, 5 years is an eternity. Mountains of clinical trial data, real-world implementation evidence, it's all accumulated. So the mission of our deep dive today is to walk you through the 3 major pillars of this 2026 update.
We've got the optimization of antiretroviral therapy, the redefined protocols for preventing mother-to-child transmission, and an aggressive, newly structured push regarding tuberculosis prevention.
Exactly.
Now, I think it would be incredibly easy to look at a WHO release like this and just see this daunting list of very long, hard-to-pronounce medication names.
Oh, absolutely. It's dense.
Very dense. But we want to extract the why behind those names. Why should you care about a shift in global health protocols? Reading through this January 2026 update, the overarching theme is just striking to me. The WHO, they aren't just tweaking a chemical formula here or there. They are fundamentally restructuring how humanity manages a chronic, complex condition.
The stakes outlined in the text are incredibly high. The WHO is laying out an evidence-based, highly cost-effective strategy here. Their stated goals are unflinching. They want to improve treatment outcomes, drastically reduce HIV-related mortality, and accelerate the progress toward ending AIDS as a public health threat globally.
It's a huge undertaking.
It is. It's about taking the ideal, highly controlled successes of a laboratory and making them functional, accessible, and realistic for millions of people navigating completely different, often strained, global health systems.
Okay, let's unpack this. I want to start with that first major pillar, which focuses entirely on optimizing antiretroviral therapy, or RT.
Right, the anchor treatments.
Yeah. For anyone following this space, HIV medications have evolved from these incredibly toxic early iterations into highly refined regimens. This new guideline plants a very firm flag in the ground regarding the preferred anchor for treatment.
They do.
The WHO has unequivocally confirmed that dolutegravir-based regimens remain the absolute preferred option, and they emphasize that this applies to both initial treatment, so when someone is newly diagnosed, and for subsequent lines of treatment.
That reaffirmation of dolutegravir is critical because of its high efficacy and high genetic barrier to resistance. But what makes these 2026 guidelines so pragmatic is how deeply they address what happens when a treatment inevitably stops working.
Because it doesn't always work forever.
Exactly. Clinical management isn't a straight line. Sometimes a patient's current regimen simply loses effectiveness against the virus, and the clinical team has to pivot. In those scenarios, where a specific class of drugs called a protease inhibitor is required, the WHO has instituted a major update.
Let's break down that terminology for a second, because protease inhibitor sounds really dense. Think of a protease as a biological pair of scissors that the HIV virus uses to snip its own proteins into usable pieces so it can mature and infect other cells.
That's a great way to visualize it.
So a protease inhibitor is a drug that basically gums up those scissors. The virus can't cut its proteins, so it can't mature, but the older versions of these chemical scissors had side effects or resistance issues. In this update, the text notes that darunavir/ritonavir is now the newly recommended preferred option.
Right, officially replacing earlier preferences like atazanavir/ritonavir or lopinavir/ritonavir.
Which is a big shift.
It is a massive shift. Shifting a preferred recommendation to darunavir/ritonavir at the WHO level sends a seismic signal to national health programs, to pharmaceutical manufacturers and global supply chains.
It trickles down to everyone.
It tells every clinician from Berlin to a rural clinic in sub-Saharan Africa that, based on half a decade of accumulated evidence, this specific combination is the safest and most effective next step for their patients who need that intervention. It harmonizes the global standard of care. And when you do that, it drives down manufacturing costs and streamlines distribution.
But then the text immediately follows that up with a recommendation that honestly made me pause and question the logic. They explicitly support the reuse, they actually call it recycling of certain medications in subsequent regimens.
Yes, the recycling strategy.
Specifically, they mention reusing the drugs tenofovir and abacavir. Now, my first instinct as a layperson is skepticism. If a patient's regimen is failing because the virus is outsmarting it, wouldn't a doctor want to completely clear the board? Why on earth would the WHO recommend keeping those same failing drugs in the rotation?
I get that. That skepticism makes complete sense if you view medicine purely through the lens of a single patient in a vacuum with unlimited resources.
Right.
But the guidelines support the reuse of tenofovir and abacavir because global health doesn't operate in a vacuum. The text points to improved outcomes, sure, but the heavy lifting in this decision comes down to what the WHO calls programmatic advantages and potential cost savings.
So we're talking about the sheer logistics of a health ministry actually trying to buy and move these drugs across a country.
Exactly. The West often operates with this obsession for the absolute newest drug on the market. But on a global scale, supply chain continuity is actually a wildly effective medical intervention.
How so?
Imagine a rural clinic in a developing nation. If a patient's first-line regimen fails, that clinic cannot magically spawn entirely new, highly complex, and vastly more expensive second-line chemical compounds overnight.
They just don't have the stock.
Right. If a national health program is already purchasing massive quantities of tenofovir and abacavir, they already have established distribution networks, storage protocols, and deep clinical familiarity with those specific drugs.
So, by proving that you can safely and effectively integrate those existing drugs into the patient's next line of defense.
You prevent a massive logistical bottleneck.
Exactly.
It prevents health systems from having to reinvent the wheel every time a patient needs a new regimen. It is a brilliant, pragmatic approach that maximizes global resources while maintaining rigorous patient outcomes.
That economic and logistical paradigm shift makes a lot of sense. But the guidelines don't just focus on the supply chain. They make this massive leap regarding the day-to-day reality of the individual taking these medications. The update formally recommends the use of long-acting injectable antiretroviral therapy in specific circumstances.
Yes, specifically for adults and adolescents who face challenges adhering to daily oral regimens.
We are seeing a major evolutionary step away from the burden of daily pills here.
We really are.
Because the psychological load of a daily pill is immense. Taking a medication every single day at the exact same time, without fail, for the rest of your natural life, it's exhausting. The analogy that comes to mind is that moving to a long-acting injectable is like putting your treatment on cruise control.
That's a perfect way to frame it.
Instead of that daily alarm reminding you of a chronic condition, you receive a sustained release that frees up your mental space for months at a time.
And adherence, which is the medical term for taking a medication exactly as prescribed, is the single most critical factor in keeping the virus suppressed. But human lives are incredibly messy and unpredictable.
Yeah, people travel, they work irregular night shifts.
They face deep social stigma and might desperately want to avoid having identifiable pill bottles sitting on their kitchen counter, or they just experience profound pill fatigue. By endorsing long-acting injectables, the WHO is demanding that the medical system adapt to the complicated reality of a patient's life, rather than forcing the patient to constantly mold their life around a rigid pill schedule.
The text takes that philosophy of simplification even further, too. For individuals who are clinically stable, the update also recommends oral two-drug regimens as a treatment simplification option. Less medication circulating in the body, fewer pills to swallow, but maintaining the exact same effective viral suppression.
That idea of aggressively removing friction for the patient perfectly bridges into the second major pillar of this document. It shifts from reducing the friction in an adult's daily routine to reducing the friction in one of the most emotionally and biologically complex areas of human health, which is motherhood.
Yeah, let's look at how the WHO is redefining maternal care and the management of vertical transmission. So, vertical transmission refers to the passing of HIV from a mother to her child during pregnancy, childbirth, or breastfeeding.
Right.
The WHO acknowledges that despite incredible global progress in preventing these infant infections, transmission is still occurring, and a highly critical window of risk happens specifically during breastfeeding.
What's fascinating here is how the WHO balances two entirely competing life or death imperatives.
Yeah.
On one side of the ledger, you have the absolute necessity of preventing a newborn from contracting a lifelong viral infection. On the other side, you have the immense nutritional, immunological, and psychological benefits of breastfeeding.
Which you can't just ignore.
You can't. In many low-resource regions, safe alternatives to breast milk like formula combined with reliably clean, uncontaminated water simply do not exist. Formula mixed with unsafe water can be a death sentence from diarrheal diseases.
Which makes the wording in this update feel incredibly deliberate. They advocate for a person-centered public health approach that explicitly supports maternal choice alongside infant well-being. But let's get into the actual timeline they are laying out for breastfeeding mothers living with HIV because, again, the skeptic in me wonders, isn't any prolonged exposure inherently dangerous?
It's a valid concern.
The WHO recommends exclusive breastfeeding for the first 6 months, then continued breastfeeding up to 12 months, and possibly extending up to 24 months or longer. That is a massive window of exposure.
The timeline is extensive, yes, but it is bound by a non-negotiable caveat. That extended breastfeeding window is recommended strictly and exclusively alongside effective maternal antiretroviral therapy, along with appropriate complementary feeding.
So the mother has to be fully treated.
Exactly. The mother's viral load must be fully suppressed through rigorous adherence to her own treatment. Her suppressed viral load is the primary, impenetrable shield protecting the infant.
The text also outlines a secondary shield, which is infant prophylaxis. The guidelines mandate that all HIV-exposed infants receive 6 weeks of postnatal prophylaxis, with the preferred baseline medication being nevirapine.
Nevirapine provides that baseline standard of care for all exposed infants, but the WHO recognizes that risk is not uniformly distributed. For infants identified as being at a higher risk of transmission, the guidelines dictate an enhanced approach, specifically an enhanced triple drug prophylaxis.
They're stepping up the defense.
Exactly. Furthermore, the protocols allow for extended infant prophylaxis to be utilized until the maternal viral suppression is completely achieved and verified, or until the breastfeeding process has completely concluded.
It's an overlapping safety net. You treat the mother to suppress the virus, and you give the infant a tailored level of prophylactic medication based on their unique risk profile, keeping that safety net deployed for as long as the exposure risk exists.
Right.
It really highlights how far the medical community has moved from the old days, where an HIV diagnosis might have meant an absolute traumatizing prohibition on breastfeeding, regardless of the risks of local water supplies.
The evidence-based medicine detailed in this 2026 guideline empowers a mother with choices. It's backed by a rigorous scientific framework that stubbornly protects both her dignity and her baby's survival.
We need to turn our attention to the third pillar of this update, which addresses an incredibly sobering reality. When you talk about HIV on a global scale, you are forced to talk about the shadow epidemic that rides right alongside it. The WHO text highlights a stark, devastating fact. Tuberculosis remains a leading cause of death among people living with HIV.
Because HIV fundamentally attacks and weakens the immune system, leaving the individual vastly more susceptible to developing active, aggressive TB. You simply cannot claim to be managing HIV globally if you are not simultaneously and aggressively preventing tuberculosis. They are intrinsically linked, compounding epidemics.
Here's where it gets really interesting, though. To drastically improve the uptake and completion of TB preventive therapy, the WHO has announced a newly preferred preventative treatment regimen for adults and adolescents living with HIV. It's referred to as the 3HP regimen, which stands for 3 months of weekly isoniazid plus rifapentine.
The strategic shift to 3HP is driven entirely by the realities of human behavioral science. Historically, TB preventative treatments were a monumental burden. They often required patients to consume daily pills for anywhere from 6 to 9 months.
That's a huge ask.
It is. Put yourself in the shoes of a patient you are already taking daily antiretrovirals to survive HIV, and the clinic hands you another massive bottle of pills and tells you to take them every single day for the better part of a year to prevent a respiratory disease you don't even currently have.
The drop-off rates must have been catastrophic. Once a patient feels fine, or they just get utterly overwhelmed by the sheer volume of pills they are swallowing every morning, they're going to stop taking the preventative meds.
And they did. The failure to complete the full course of therapy was a massive vulnerability in global health. Condensing the regimen changes the behavioral math completely. 3 months of a weekly dose means taking about 12 doses total.
Wow, so 12 weekly doses compared to roughly 200 daily doses.
Exactly. By radically condensing the timeline and the frequency, the WHO is mathematically ensuring that completion rates will skyrocket. Note that other WHO regimens remain options, but this is the preferred push because it works with human nature, not against it.
The text explicitly states that the broader goal here is mainstreaming interventions that facilitate better integration of services. The aim is reducing TB-related mortality while simplifying service delivery. Simplification is truly the beating heart of this entire January 2026 update.
In the realm of public health, simplification is not merely a convenience, it is a highly potent clinical intervention. Every single time a health system removes a barrier, whether it's reducing the number of pills through a two-drug regimen, extending the time between doses with long-acting injectables, or slashing a preventative TB regimen from 9 months down to 12 weekly doses, you tangibly increase the likelihood of a human being surviving and thriving.
The WHO included a statement in their release from Dr. Teresa Kasayeva, the director of the Department of HIV, TB, viral hepatitis, and STIs in Geneva. She notes that these updated recommendations reflect a commitment to ensuring that people living with HIV benefit from the most effective, safe, and practical treatment options available.
If we connect this to the bigger picture, Dr. Kasayeva follows that up with a sentence that crystallizes the entire document. She states, "By simplifying treatment, improving adherence, and addressing persistent gaps in prevention, they will help countries strengthen HIV programs and save lives."
So what does this all mean for you, our listener, as we wrap up this analysis? Synthesizing this massive January 2026 update, the clearest takeaway is that HIV management has entered an era of intense, pragmatic refinement. It's about smarter drug sequencing, knowing precisely when to deploy dolutegravir, when to pivot to darunavir/ritonavir, and when the smartest logistical move is to recycle tenofovir and abacavir. It's about highly tailored, person-centered maternal care that fiercely protects a mother's choice to breastfeed for up to 24 months, utilizing overlapping shields of maternal RT and infant nevirapine.
And that aggressive TB prevention.
Right, utilizing that 3-HP weekly regimen to make completing therapy a realistic sprint rather than an impossible marathon. The entire global framework is pivoting to focus relentlessly on patient adherence and quality of life. Thank you so much for joining us on this deep dive into the 2026 WHO clinical management updates. We love unpacking these vital topics with you, and we'll catch you on the next one.
Before we go, this raises an important question, something for you to mull over long after you finish listening today. We've explored the shift toward simplified care, specifically the introduction of long-acting injectable antiretrovirals instead of daily pills. As treatments physically shift away from being a daily, highly visible reminder of a chronic condition, how might this radically alter the daily psychological burden for millions of people? If an individual only has to think about their medication a handful of times a year rather than the very first thing every single morning, how does that shift their identity? Does it finally allow millions to shed the constant mental label of being a patient and return to seeing themselves simply as a person?